Good morning and welcome to our monthly webcast. I am Samir Mehta and I'll moderate you through another very challenging case. This is session number 58. Samin, good morning to you and Anu. Are you all set for this case?
Guest here, which guest for our webcast, but of course, director of our clinical trial unit at Mount Sinai, Roxana Mehran. So the topic which I'll be talking today pertains to some of the expert comment and her interpretation of the data, so that she will be part of this morning webcast.
Roxana, good morning to you.
Good morning, and thank you, Dr. Sharma and Dr. Kinney, for having me here.
We need to, we have your volume. Roxana, congratulations to you, to Samin and to Anu also about the Medtronic core valve. Glad that we'll soon have another option available to us.
Yeah, well, actually, not only that, the first time ever that the TAVR procedure superior to bypass surgery in some respect. Lower mortality, slightly lower, although non-statistically, but lower CVA rate. Those are the, I would say, the real highlights, and will revolutionize this field completely, because we were, until now, I always used to say, the Achilles heel of TAVR procedure was the higher CVA rates compared to CABG, or surgical valve replacement. But clearly that's shown, and I always also want to make a point, that it is the smaller sheath size which will make the difference, although they have the data that you really have a CVA when you release the valve and all this. All this is basically the Ramus material during the passage of the device. It embolizes, and clearly shown the lower the sheath size, lower is the CVA, and therefore it's a very exciting time for us for the years to come. And I think the stage has been set now. From the FDA point of view, they're already working with the intermediate, but already in the plans to go to a lower risk of the STS of less than 4%.
So do you already have other institutions and physicians calling in to schedule patients?
Well, I mean, that has been the part of it always. We are now about 12 TAVR cases per month, but now with this, there has been a more interest. Knowing Dr. Adams presented at the central stage that our core valve randomized trial, and will increase the referral pattern further. But more important is that people actually now asking, even at age of 60, 70 with a low risk, that how we can have a core valve and not go through the randomization process, which is a tough one, but we deal with case by case.
Samin, you've had extensive experience with this. We often get numerous requests also through the website. Is there possibilities of physicians coming and watching TAVR procedures?
Yeah, we actually will be one of the training site for the Medtronic core valve. We started training the sales force, the physician training they were trying to start, but I think because of few issues maybe delayed a little bit. But yes, we'll continue to do that, and people who come, various physicians for various other the training sessions, they always have an interest and they see our procedures being done. But yes, your answer to your question, systematic training, we will start soon for the physician's point of view. Right now we are doing it for the sales force of Medtronic.
Anu, to you and Samin are also many congratulations for having done an outstanding case. We've received numerous emails about the anomalous RCA intervention.
And with the same note, we actually had a lot of requests to do a case for the LIMA, and Anu had an ideal case waiting to be done for the live webcast, that LIMA to LAD anastomotic lesion, because there were a lot of requests also, because we know that compared to our native vessel, intervention of internal memory grafts, particularly LIMA, is more challenging. Many steps are required to come out successfully without causing problem, and this will be the highlight case. This will be the first ACC webcast case involving LIMA to LAD, although we had done one earlier in our CCC live.
Wonderful. Please take us through it. And Roxana, thanks for joining us. We'll get into your intellect about various aspects of the trials which Samin is going to be talking about.
Okay, we start with our same. We can go to the slides now. The supporters, same keep increasing because of our wide popularity. These are the disclosures, and we will add Roxana Mehra's disclosure a little later. Now, this is a 66-year-old patient who had a prior bypass surgery and PCI of SVG to Ramus, presented on February 7th with crescendo Class II angina. He actually had a PCI a few years ago of the vein graft to Ramus, about 3-4 years ago, has done fine, but now has new onset of crescendo Class II angina and has a stress MPI which revealed moderate size severe anterior ischemia with normal ejection fraction. And the patient was on maximized on medical therapy with the risk factors and medications shown here. And Anu will take us through, in this case, who has extensive 3-vessel disease, and will show with the angiogram.
So this is where is EF, mild hypo in the, I think, antro base, but otherwise maintained LV function. This is this vein graft, which is a Y graft that is going to OM1 and OM2
Ramus.
and Ramus. Yeah, Ramus and OM1. And then what happens is there's a stent in the distal portion of that upper part of the, that is what was intervened last time. And this is this LIMA. If you see the distal, how the LIMA, very tortuous, it is attached to the diagonal and LAD. And this is a native LAD. You see moderate calcium there, but the lesion is in the native vessel after the attachment of the LIMA.
Samin, we see it very clearly, and I'm sure this question is going to jump out from many viewers. You've got exceeding tortuosity in the LIMA. Game plan should be simple. Why not just go ahead and direct stent that and get over with it?
Well, that is a very good point. Again, you know, to make the case interesting, we always have to select from some educational point of view. As you can see here, just before the lesion, there is a moderate calcium. Remember the shadow seen during during cardiac silhouette, that is called moderate, and if you see a tramp track, it's just the severe calcification, and you know, we call it a moderate or severe or marked calcification. So after the lesion itself is not calcified, there is a moderate calcium proximally, then there is aneurysmal segment, and that's where the heavy calcium. So you are correct. The question is that should we do rota or just do a balloon angioplasty, see the lesion opens up, and then put a stent? So absolutely, and this is what, knowing this tortuosity, that there is more stake, more complication, and this supplies the entire anterior wall with a diagonal and LAD. So you want to keep it least traumatic intervention. So in this case, what we are going to do is we'll do I call it a calcium test, that you bring a balloon, inflate at 8 atmosphere, don't go high, and see if you can open the lesion. If you cannot open the lesion, then you exchange to the rota and put a small burr. But if you can open the lesion, then you are done. You don't need any fancy or more debulking decalcifying device.
Well, seems a very acceptable strategy.
You think we'll need a rota in this case?
Probably not. Coming to the challenge, it's important just because it's tortuous before the attachment of the diagonal. So we are dealing with the distal anastomosis of the LAD, at which time if there is some concertina effect which we may see with this LIMA, we will cause ischemia of the diagonal. So that is why this case is challenging. Even though it's a short lesion, we hope it will dilate with just balloon PTCA. But otherwise, we will be ready for the rota.
And Anu, you have
ask now Roxana, who is actually the leader in moderating. Everybody loves her to be on the panel by her experience and expert comments. Roxana, you are in the ACC, and we are doing this case for ACC. What advice you will give us? How should we deal with this lesion?
I mean, I think your points are all very well taken. There is calcium just proximal and distal. It's really important in the post-bypass patients. Direct stenting would be ill-advised here, so I really agree with that there's more calcium there than meets the eye, as we always know, and I think your test is something that a lot of our European colleagues do. They in fact go in much higher atmospheres with their balloon and try to really do that. But I think your technique in knowing on going there in a low-ish atmosphere to see if the lesion gives way, and then proceeding with a stent implantation is a fantastic thing. I mean, I can imagine that the rotor wire down this artery can really wrinkle it up, and I think a news point about that diagonal coming off the right before the tortuosity is really, really well taken. So it's not something you just want to try at home with a rotor wire if you're not really a very good and proficient operator. So I totally agree with your approach here.
All right, so that we've got everybody's agreement. We actually have about 22 cases of the LIMA to LAD anastomotic lesion or the native LAD after the LIMA calcific requiring rotation atherectomy. And we almost do one case during our symposium in June. So that this case, I expect and hope we don't need to do rota, but if we need to do, be it may, and can use a small bar. So with that note, we come back to our presentation in terms of appropriateness. This patient is on maximum medical therapy, has a significant ischemia, so that's the right thing to appropriate to proceed for intervention. The 2 points which I want to talk about, one pertaining to this case, the status of LIMA intervention, and second is the recent trials of bivalvular and PCI, which really took the center stage end of last month in Washington in our ACC I2 summit. Now clearly the LIMA intervention, I can tell you there is very little published in this field. Now we know the LIMA, if you can have it, clearly the internal memory graft patency of 90+% at 10 years, the original paper from Cleveland Clinic, still holds true. And we know that, like this kind of case, this actually, the lesion truly is in the native vessel. So majority of these patients who present, the lesion is in the vessel, native vessel, not in the graft. So that this is really underscore the importance of the patency of the LIMA and also the risk factor modification to really prevent the progression of disease, atherosclerotic disease in the native vessel. Now, and I'll ask, since Anu will be doing this case, that talk about where some specific technical issues for the IMA intervention, particularly LIMA, because LIMA interventions is very rare. We do it, but 90+% cases or 92% are the left internal memory intervention. So Anu, you can tell if you want to take us through various specific technical issues.
Yeah, one is I think once we know, you do a non-selective picture like we have done here of the LIMA, and this is where you see there is a tortuous vessel. How do you take care of this is that you have to have a long sheath and then you decide on your guide. I think most often the IMA guide, since it has a small hook, gets into the LIMA. But what you can have is you just have to be careful, just don't go with the guide itself to engage the vessel. Go with your regular diagnostic catheter, then exchange it over the wire, and that is where you can avoid the dissection of the IMA or as well as subclavian. Both these vessels are very notorious for dissection if you are not careful while engaging. The second thing that the most important thing that happens is that when you are wiring, especially like this, when you see what we call as a curly Q or a very tortuous LIMA, that how you're going to wire. You can go start wiring with your regular workhorse wire, or if you want to even think of the soft tip fielder wire, you'll be able to wire it, but you just have to be careful that as soon as you wire, what you can see is accordion. And once you see accordion, what can happen? Two things can happen. The flow of the vessel will stop, and that itself can give rise to chest pain, EKG changes, which at many times could be disastrous. That's why you have to be ready that when you're wiring, you may be able, if you are seeing these changes, be ready that you want to wire, dilate wherever the lesion is, and able to get the device down. Second thing also will happen is as soon as you have accordion, what next things you will see is that you will be unable to get your device down there because of the accordion. So many times what we have to do is you have to dilate the LIMA accordion to get your balloon or even sometimes the stent down to the native vessel. And other thing also, the last one that we are saying is your guide, you go with a shorter guide which is usually you get 85 or 90 centimeter guide, so that you will be able to get to the distal anastomosis to avoid all this tortuosity.
Okay.
Six French system you have there?
Yeah.
In any difficult takeoff or cannulation of the LIMA, have you ever needed to go left radial?
That's the other point we wanted to say is, we get special reference just to take care of this kind of a LIMA intervention. If you know it is very tortuous, and the subclavian itself is tortuous in many of these cases, that you are unable to engage. There are two ways of wiring the LIMA. Many times your guide does not engage the LIMA. You can leave the guide at the ostium and wire the LIMA with the floppy wire. And once you are down there, you can get over the wire, means with the balloon support, then you can engage the guide. If that also is difficult, you have to go left radial to do the procedure.
Yep. Yeah, and left radial will be a little easier, although cumbersome for the operator for his or her back pain, even if you bring the arm on other side, but makes the procedure successful and some of these very tortuous cases. Another point, which is the long sheath. I always say the long sheath is a winner in these cases with the guide support. The 45 centimeter of Terumo, there is another one, Cook is 55, right? So the Cook is a little longer, 55, although there is a 90 centimeters also, but I think 45, 55 centimeter gives you good support. So I say that long sheath make your 6 French, guide to 7 French. So they really give very stability that I start these cases with the long sheath. With that note, I'll start with some of the scanty literature on this subject. And this actually one of the paper in 2000 with second author with the George Dangus from the data from Washington Hospital Center of 200 plus cases. This actually, in my opinion, is the best description of intervention in the internal memory procedures, internal memory grafts. These are 200 cases, 202, 85% LIMA, 15% RIMA, and they showed basically that, as you can see, that based on where your lesion is, ostial, shaft or anastomosis, anastomosis is almost 2/3, that PTCA is more commonly done compared to bare metal. Remember, this is the data from 2000, so it's a bare metal, no DEF. But just to say that PTCA does, we often use anastomotic lesion PTCA compared to bare metal. This is again that I would say the feeling we used to have back in 2000. And what it showed, that you can hear stent versus PTCA, that actually the PTCA does better in MI, overall death, MI and TLR compared to your stent, again with the bare metal stent. Now things have changed since then, but key point is that the advocacy that PTCA for distal anastomotic lesion is good enough. You don't have to put a bare metal stent and so. Then the recent registry by Brilakis from our ACC NCDR of a large number of interventions from the vein graft, then basically showing this is like 200,000 patients, the follow-up. That is that when patient present in the prior CABG cases, majority of the time we go to the native vessel. And with the prior CABG, how long the timing from the CABG, you start doing the CABG intervention. But majority of the time when we work on the CABG patient, it is the intervention of the native vessel in 60-70% of cases. And of course, you see the vein graft in about 20-30, and the arterial graft makes very small percentage, about 2% of cases. And shown that yes, that once you do the intervention, whether native vessel or the graft, whether the saphenous vein graft or arterial graft, that beyond the native vessel, when you go to these grafts, have a higher complication rate, almost double compared to native vessel. So if you have a choice, vein graft versus native vessel, or vein graft or arterial graft, you try to go to the native vessel. In this particular case will not be possible because you have the LED completely calcified and occluded. So here you want to go through the graft. But just wanted to point that anytime we are thinking about graft PCI, if you can get access to the native vessel, it will be preferred because that will have a lower complication rate. In this field, actually, we presented the data last year. The manuscript is still going through a few revisions. That outcome in comparing the second generation versus first generation or BMS. This is actually see here about 150 cases, and you saw the BMS is the first category, first generation DES, which is Texas or Cypher in the second, and the second generation the third. Clearly that first generation DES were worse than your BMS. and of course worse than your second generation DES at 1 year endpoint of the MACE, death, MI and TLR, and similar at 2 years. So clearly first generation, I think part of that is stiffness. So it is better probably either do a PTCA or BMS if you don't have a second generation DES. But we know now the second generation DES are quite well, decrease the TLR, so you will see from 9.8% to 5.9%, so should be preferred in the treatment of LIMA intervention. So this is again the field evolving, very little publication, but just wanted to highlight, if you got a good result with a PTCA, don't be you can just walk away from it. Don't be obliged that you have to put a DES. But if you want to put a DES, of course the second generation DES is preferred. And these are the overall outcome at 1 and 2 years. Now then come to the recent trials of the bivalvulotin in PCI. Now remember, there are ample literature and numerous trials involving thousands and thousands of patients in last 1 decade. Actually more than 10-12 years, which we have done in various clinical settings, stable patients, acute MI, non-STEMI, acute coronary syndrome, and one message was consistent. And consistent message was that bivalvulotin use against backdrop of heparin plus 2B3A, but everybody got 2B3A bolus and infusion, was associated with decrease in major bleeding to half, from 4% to 2% in replaced to acute PCI, and similar data in patient in Horizon AMI. So clearly this field was kind of set from everybody that bivalvulotin decreases bleeding and should be the preferred agent, and particularly by virtue of decreasing mortality in become the preferred anticoagulant in patients with primary PCI. But now this actually came to the question in the 4 recent trials presented, one in the China, which is a bright. I have very little data on it, but I'll show you what we have. But 3 of them, HEAT PPCI, Brave 4 and Naples, Italy, Germany and Europe, and showing England, basically that all the concept basically is that why do you need a 2B3A? It should be bivalvulotin against unfractionated heparin and keep 2B3A only as a bailout, and particularly at the backdrop of more stronger antiplatelet therapy of prasugrel and ticagrelor. And what it showed is totally different what we so far we knew. HEAT primary PPCI trial basically took almost every patient. There were some ethical issues because consent was obtained later and so on and so forth. I'll go away from it, but whole idea was that almost every patient was randomized and included in the analysis, and basically showed that bivalvulotin versus heparin, and you can see 2B3A use, but much smaller. It was 3.5. It's a little misnomer, but it's a 13.5 and 15.5, identical in both bailout, but many of these patients got prasugrel and ticagrelor and radial access in majority of them, you can see here, and various individual the devices. But what they found is the MACE rate 5.7 in the heparin group and bivalvulotin 8.7, 3% higher in the bivalvulotin group, making a p-value of 0.01. I can tell you for everyone in the hall, and I know that Roxana was one of the moderator in that panel, that took us as a surprise because we believed in, and we know that in day-to-day, since we adopted using bivalvulotin in our routine practice, that it was associated with the lower bleeding, and if not, it was at least identical in terms of the MACE rate. Yes, the issue about the stent thrombosis always have been surfaced up, but that we were able to neutralize by the prolonged infusion. But this one was a clear finding, and the second, the curve starts separating very early, as you can see within 2 to 3 days. Then why this difference occurred from 3%, and it basically by the reinfarction and TLR. You can see here, which is always almost double to triple in the bivalvulotin group compared to unfractionated heparin group, and I think part of that was the stent thrombosis. You can see the stent thrombosis in the bivalvulotin was 3.4 versus 0.8. I can just to say one thing, that if we learn that if you stop the infusion of bivalvulotin at the end of their PCI, you will have a higher stent thrombosis. We don't need to do any trial. We knew in Horizons AMI. And that's why we increase the infusion rate to about 1 to 2 hours post. In this group, they stop the infusion at end of the procedure. So that may be translated into a stent thrombosis, and in my opinion, translated into the myocardial infarction rate, while there was no difference in bleeding. Why? Because no longer 2B3A is being given as a bolus and infusion. perfusion. It was only bailout 15%, in the bivalvulotin 13%. So key is that you take away the routine 2B3A. You don't increase the bleeding, but you definitely bivalvulotin has a higher stent thrombosis as well as the MACE rate, particularly from MI. So Roxana, you want to comment on this? Because this is a very major, our game changer, or I would say mind changer for us, who completely believe bivalvulotin in acute MI setting.
Roxana, as you interpret this and give us your thoughts, how much also do you think is the transradial contributing to it?
So first and foremost, I think it's important, since the disclosure slide was not up there, for me to disclose that I have led and worked very closely with Greg Stone on the Horizons AMI study. I was the head of the clinical coordinating center, so I think that's an important disclosure. But I think first and foremost we should congratulate the Rod Stables and his team in really performing this incredible trial in a single center, 2,000 patients almost, with STEMI. Nobody was left out. 80% radial, 90% novel agents. So those are all very contemporary PCI and really sort of futuristic for acute MI care, and I think that's really should be congratulated. Their door to balloon time was extremely short. They did a fantastic job treating these patients. I think when you look at these data, there's no question that we're not surprised by the fact that there's more stent thrombosis. This was seen in Horizons AMI, although in a much lower rate, 1.3% acute stent thrombosis in Horizons AMI. Here it was 3.4%, and one is always concerned about, was the bivalvulotin dosed correctly, given for a prolonged period, enough period of time, where most of these patients were just given the novel agents, which we know takes a couple of hours to take place. And we all know that there's a tail in heparin which helps. So all of this is extremely important to think about that. But what I was two things that I commented on both on the panel, and I continue to talk about that most of this was driven by reinfarction, and reinfarction in the setting of a STEMI is extremely difficult, because reinfarction really is telling you that there is a extension of the myocardial infarction that's already going on. If this was true reinfarction, you would at least like to see an effect on the mortality. And so therefore, of course, if this is all driven by stent thrombosis and urgent TLR, obviously this was their definition of MACE, and it still would show the same results. I think what this trial, the other one that I was really surprised by the lack of reduction in bleeding, 80% radial. I'm always still concerned that, are we ascertaining the bleeds in a correct way? This is an open label study. Non-axis related bleeds are always reduced with heparin, but again, are always reduced by bivalvulotin. We've seen this, and as Dr. Sharma put it, there's no question that the 2B3A was in the other arm, and there's no 2B3A, 80% radial. But I want to make sure that everyone understands that there is a great paper by Steve Marceau in JACC regarding what we have seen with the NCDR registry and bleeding avoidance therapies, such as radials and the use of bivalvulotin, with major reduction even versus what was done historically, not in a prospective randomized, it's registry data. So I still am concerned that we're not seeing the difference in bleeding, but this could really be true, or it needs to be prospectively examined in a multi-center randomized study. And I think this really is a great study for us to now do a future study that is a prospective randomized study. And I challenge Greg Stone for Horizons 2 to actually randomize patients against heparin alone versus these novel agents, with the novel agents on board.
I think that probably will be the correct answer, because that's a 8,000 patient trial,
right.
And we'll do randomization has to be bivalvulotin against unfractionated heparin.
That's right.
2B3A only bailout in any of the arm. Has to be,
no question.
And will be the real answer. I know you are not a much believer of bivalvulotin, at least in reducing the mortality in STEMI patients. What is your opinion now?
I think initially when Horizons MI results came out, it was difficult to believe also, but it took us a while. we change. But I think when our practice change was the same, we used to stop at the end, and we had a couple of cases of acute stent thrombosis that happened with the patients. Some of them on the table and some in the holding area. When we then got to the bottom of the pharmacodynamics of the drug, and we know it's a 20-minute half-life, and that's when we decided that in patients who are getting that was Plavix at that time, if you give Plavix on the table, that you continue the infusion at least for between 1.5 hours to 2 hours, by which time you know the Plavix will be working, and when you stop the infusion, you will have 4 half-life, which will take another 2 hours. So you get a cover of 4 hours of the anticoagulation, and that's when we saw the change. Definitely there was change in the retroperitoneal bleed. With use of heparin, one thing that we used to see is retroperitoneal bleed, which there's maybe one case we see per year in Mount Sinai, but the stent thrombosis completely disappeared after we started this continue the infusion if the Plavix was given, loading dose was given on the table to these patients.
Good. Now, while we are getting your goal will be here, you engage the catheter, the LIMA with the diagnostic JR4, and then go with the guide catheter?
Here, since we know the subclavian is not tortuous, we'll try to do directly with the guide.
Okay.
Otherwise, normally is the same thing, that you go with the diagnostic, then over the wire, and then change to the LIMA guide. And the same question of guide selection. I think the first guide has to be depending on the guide selection will be which part the LIMA is originating from. We know 2/3 of the time the LIMA originates in the first 1/3 of the subclavian, and there is 1/3 of the time it comes from the ascending part of the subclavian. If it is coming from the ascending part of the subclavian, no torque probably is a better option as a guide. But here we know it is coming off the subclavian, so we have a LIMA.
Flush this.
Anu, have you noticed because a soft tip guide being so critical in these cases, any particular manufacturers whose LIMA guides you like?
No, I think we always use mark here.
Soft guide.
No.
Yeah, you need to stay here.
No side holes.
We have two.
You can stay?
Yeah, come and continue.
Huh? Good.
Yeah. Only problem is that we try to use, we made the point in the ACC also that mark guide we use routinely. And the same thing he made the point, Dr. Gus Prasad, that they're very soft tip. So those are the guides we use, and that actually has really decreased, I would say, the overall the guide induced dissection. Yeah.
So what I did was, we have the wire still in the guide. We have the wire in the guide. We know we are in the subclavian now, and you make sure your pressure tracing is good, no damping. If you see any damping in the pressure tracing, you absolutely do not go forward, because the subclavian, next you'll have a subclavian dissection. So here what you can do is advance the wire, and the wire is going very easy, and now you just advance the guide, you're there, take out the wire. So what we did was, you avoided one step of exchange diagnostic to guide.
But I think the point is well taken, because the internal memory, the LIMA guide, will be little trouble to make a curve, to really flick into the subclavian. If there is a difficulty, use a JR4, get the exchange length wire, and then you try to exchange with the LIMA guide, and the usual, instead of your 110 centimeter guide, you use a 85, 90 shorter guides.
And same thing, now what we're, keep looking at the pressure, counterclock, so it comes anterior and just keep coming back. Usually it will drop into the LIMA. If it does not, some die. Yeah. Now?
Yeah. Look this way.
Yeah,
There it is.
good. So you saw how it dropped down. Yeah. So low mag, you can do low mag in a way it's better, so you don't have to.
Take one picture now, just for the people
Go
to
ahead.
show.
Go ahead.
To do cranial.
Yeah.
Low mag, right?
Yep, low mag is fine. With that we have shown. Just go to the distal now.
No, you can still see the.
She wants low mag.
Yep, low mag. Yep.
Go.
That's nice. Beautiful.
Yeah, here you can see the moderate tortuosity now. And we can go back while we are getting the shaping of the wire. Now tell us which wire you are going to use.
We have a run-through wire. I think we should be able to get the run-through. If we are having any trouble, then we do is balloon support and a fielder.
Yeah. Now if we can just for 5 minutes so that I can complete my presentation, we can go back to slides please, because I need to complete our this data, and I'm glad that we had a good discussion about the heat PPCI trial. Now the second trial in the field was BRAVE 4, which was patient again in the ST segment elevation group, and this trial actually after 450 cases was stopped in Germany because of the low enrollment, and this randomized patient prasugrel with bivalirudin compared to clopidogrel plus heparin. And hypothesis was that prasugrel with bivalirudin should be superior to strategy of clopidogrel plus unfractionated heparin. And basically again here the use of various agents shown in this study, basically the majority of them got the prasugrel in the prasugrel group and clopidogrel in the clopidogrel group with a little bit of crossover, and basically found no difference of the primary endpoint of MI, death, unplanned revascularization, stroke or major bleeding. Identical, the MACE endpoints were identical, and the bleeding actually was not different. Again, why? Because of the heparin only, not a 2B3A. And you can see here that what we could do basically, that there was, by using prasugrel with bivalirudin, at least we eliminated stent thrombosis in the compared to unfractionated heparin group. Just 1 second, I'll be done shortly. The third trial was the Naples 3. Now Naples 3 was the patients, elective patients who were at high risk for bleeding, and this bleeding score was derived by age, female gender, anemia, low molecular weight, heparin, pre-PCI and GFR, that those who had a risk score of more than 10, the major bleeding is more than 5, were randomized to again the strategy of unfractionated heparin or bivalirudin, and basically it showed that in this about 1,000 patient trial that 2B3A use was 0.4 versus 0.5 versus 1.3, and event rate primary endpoint was the major bleeding as per replace 2 trial definition, which was 2.6% in the unfractionated heparin group and 3.3 in the bivalirudin group. Again lower, numerically lower, no significant difference, but numerically lower because it was only unfractionated. And as you saw, the bailout use of 2B3A was less than 2%. And where entry site versus non-entry site again was not much different between two groups. And these are the individual endpoints of death, MI, revascularization, stent thrombosis, and composite. Clearly, that little favor of unfractionated, but no difference. But just to say that heparin alone in this day and age, by our technique, was not associated with any adverse outcome compared to bivalirudin. And then, of course, these are the 1-year data, exactly identical. Now, there are 2 other trials. One actually was presented in China. We don't have much data on it, called BRIGHT trial, which will randomize about 2,000 patients to bivalirudin, unfractionated heparin, and unfractionated plus 2B3A. And they found basically same, significantly lower bleeding in the bivalirudin versus unfractionated plus 2B3A, but not compared to unfractionated group. I don't know much detail about it because it's a very little data on, but hopefully we'll submit something in the future. But just to say that clearly the bivalirudin is superior to unfractionated heparin plus 2B3A for bleeding, but if you go against unfractionated heparin, you don't lose any MACE rate, and there is no advantage of the bleeding. And so there is a one trial which we also look into it, which is the ISAR REACT 5. That is a 4,000 patients with acute coronary syndrome. Everybody will getting a heparin bolus and infusion, and will be randomized to ticagrelor or prasugrel. And of course, as Roxana mentioned, the trial of Horizons AMI2, which everybody getting bivalirudin at present, although trial has not started, and they are going to look into the strategy of the bare metal, the bioabsorbable polymer, and the metal DES. With that note, I think we are ready to do a PCI here.
Yeah, I think as you start to do that, just one final word is that all of these trials are giving the same message, but each individual trial is underpowered for those important endpoints that we talked about. And I think that all of this is really laying down the hypothesis that we need a prospective randomized study that's well powered to look at this exact question, to either prove or disprove the point of the reduction of bleeding with bivalirudin, as well as the MACE rates.
Absolutely.
So,
Okay, and now tell us where we are now.
So knowing that that was tortuous, I think if you see here, the wire went through the first couple of tortuous. It is as we reach the distal anastomosis, I have a U bend and I have stopped it there. So what you normally do is at this time, stop it, don't try to advance the wire further and go with the balloon support. We have a 2-5, since the lesion is short, we have a 12 millimeter balloon, and we have a 2-5-12 balloon.
Anu, why would you prefer the balloon here as opposed to a support catheter?
Same, we think we may be able to do it
With the balloon
with the
dilatation
balloon,
also with that.
So that,
Okay.
so now you see this wire, you
Yes.
saw that I had my U loop. I did not advance. Whenever I'm trying to advance, the guide is coming out. So what you do, you just take the balloon and then
I think that's a valuable teaching tip so that one minimizes manipulations
Yeah.
within the LIMA. Sameen, some questions have come here for you. One of them is what is your present percentage use of GP2B3A and for what cases are you using it?
Yeah, actually, I am probably the highest user of GP2B3. We go up.
okay. Now other point also that you like to make in this situation, very important, the key point in doing LIMA intervention is that when you have this kind of a tortuous LIMA and you know you have a surgical clips, it's a good thing that you go to one view so that you're not moving your camera many times. Go to one view and have your surgical clips that you have what is called as a road map. And in this case, which we see that in this particular picture that we took, this is that you take RAO 27 and 10, and if you see between, you have those clips there, where do you see those three clips, little small clips, and the lesion will be just below that, and you put it as your road map, keep it ready. If at all there is concertina and slow flow, you may not see any flow in the LIMA further down, so all you have to do is your intervention based on this clips so that you know that's where your lesion is. Go with the balloon, dilate, and quickly go and place the stent.
Okay. Now we are magnified view now.
Yeah.
We are in
So
the
now
same
if
view.
you see that in the same view, we have the clip, you don't have to give dye. This is where the balloon is, and this is where the lesion
Go
is
up.
going to be. Yeah.
Go to 8 atmosphere. That was our plan.
Yeah. Dilated.
It opened up.
Go 1240.
Now you can go till higher. Once it opened up, you know that you're not going to use any other adjunct devices. You can really open the lesion.
Okay. Down.
Right.
25, 275.
275. You want to take a picture first?
Yeah.
Yeah. We are going to take a picture now.
Okay. Now you can.
A
We can
little
just. I think we'll take a
faint-
27512 and stent.
Faint intimal disruption there, but excellent flow.
Yep.
Sameen, any particular stent you like to use in tortuosity?
Well, I think to
something like
me,
this?
the newer generation of
Second
the Promus
generation.
Premier, Science Expedition, and Resolute Integrity, all three in terms of deliverability point of view has become identical. Compared to before, earlier generation of Giants like V or Giants Prime has a lower deliverability. Same thing with the Promus, but now with the Promus Premier and Giants Expedition, it's becomes identical. So no longer advantage.
Absolute overkill trying to chase that distal lesion?
Yeah. Well, I mean, you could do it, but I think it remains, we'll see. Part of that is a little intramyocardial. If you need to, you put another stent, but in this particular case, I think you want to just leave it, those moderate lesion, and make a more aggressive the modification of the risk factor so that does not progress. In this particular case, actually, patient was on clopidogrel and they did a PRU, and PRU was 348. So basically, it's a non-responder. So they, because of patient has slight anemia, because patient has some thalassemia?
Thalassemia minor.
Thalassemia trait, and we felt that this should get different antiplatelet therapy. So the patient was loaded with the ticagrelor 180 milligram, and will get a 90 milligram dose.
Too far?
Too distal.
Yeah.
Wait. Yeah, that's probably, yeah. I think you're good. Here goes. You have to give dye.
Okay. Yeah, we're taking a picture now. This is a good position. Take a cine. Good. No, that's good. That's how it should work. There was nothing there. Yeah.
Okay, go up.
Go up. This is 2.75, 12 Promus Premier. Okay. You can easily go to 14 atmosphere. So you don't have to post dilate.
Down.
Go up again. 2 inflations.
Down. Some dye. You want to take a cine?
Yeah, sit.
Looks good.
Short and sweet, huh?
Yeah.
Good. Take the wire out and we'll give.
So I think now what you have to do, your final picture has to be your low mag, and make sure your proximal, especially the ostium of the lima and the proximal portion of the lima, everything is okay. And same, your vasodilator strategy in this situation is verapamil. So we're just going to give some verapamil.
Samin, on the topic of cardiac surgery and
You didn't give
lima,
the
are your
percentage.
surgeons doing bilateral
You were asking
memories?
the question
What?
of the need for 2B3A.
Yeah. Basically, the point was that 2B3A in our lab now is about low teens, 12-13%, and those are the cases actually I use, particularly in complex cases. Give a bolus. We do not give infusion at all. The no infusion, only bolus of 2B3A, which is integralin at this time. A very rare case of the other 2B3A or infusion only will continue in cases when there is a side branch closure or extensive dissection. But other 98-99% of this 12% will be only 2 boluses of integralin. Very rarely will give a F6MF bolus, particularly in STEMI setting, but kind of to me that molecule has almost disappeared because of the thrombocytopenia. But that also we give bolus only. So otherwise, it's basically 2 boluses of the integralin eptifibatide at 10 minutes apart, and many times we just give 1 bolus. And what we also do, once you give the bolus of 2B3A, you stop your angiomax at completion of procedure, because that you can stop it, because now that additional time window of your 60 to 90 minutes while your antiplatelet therapy taking effect, given protection by the 2B3A inhibitor. So that is basically being done at present, but I would say that 2B3A is going less and less, and now rarely used once you are using our more potent antiplatelet therapy of the prasugrel or ticagrelor. And that's what the field, and yet we continue to have a better outcome and has eliminated stent thrombosis almost completely.
Significant myocardial bridging there?
Yes, yeah. This one actually has become, this is not uncommon, it become more prominent after you have opened the vessel,
right.
And basically with the vasodilators. So what it does, basically open proximal and distally and make the segment hyperdynamic. So with that note, I think we can come back to our last few slides of the take-home message of a LIMA intervention in the recent bivalvular trials. That intervention of intermemory artery requires special consideration, which we have highlighted, due to associated potential complications of dissection, spasm, and no reflow. PCI involving PTCA alone or second generation DES provides better outcomes, we understood, compared to your first generation DES. Second, the recent 3 to 4 randomized clinical trials of bivalvular versus unfractionated heparin alone, except with a bailout, 2B3A during PCI did not show any reduction in major bleeding, and rather higher ST stent thrombosis with bivalvular arm in the HEAT PCI. These trials have provided newer clinical perspective on use of cost-effective unfractionated heparin during PCI. So how we are going to change our practice, because as the latest ACC NCDR data are that in United States, 73% of the PCIs are being done with bivalvular. So it's a very large number. Whether it should change or where will stand, knowing that yes, it does add to the expense, but it decreases the overall cost because of decreasing the vascular complication. Because anytime we go with a heparin, our routine practice is that using 2B3A in large majority. But we also learn now, based on the recent data, that even in STEMI setting, that you use 2B3A only as a bailout agent and should not be used routinely. Now, it takes to our 3 questions. That following are the true statements regarding internal memory artery PCI except, that means which is wrong. DES is superior to BMS. PTC of internal memory artery anastomosis associated with high MACE rate. DES use has shown to improve survival. The IMA PCI is associated with higher complication than native vessel, and the IMA PCI is technically challenging. Clearly, we have emphasized all those points. Then, following are the recent randomized trials of bivalve routine except HEAT PPCI, Naples 3, Brave 4, Replace 2, and Bright. And the last question is the recent randomized clinical trial of bivalve routine versus unfractionated heparin has shown the following: lower bleeding rates, lower MACE rates, higher stent thrombosis in some trials, higher TLR rates, lower MI rates in bivalve routine group compared to unfractionated heparin. And I think we have made very clear points of these. Should be simple to answer.
Anu, take-home message from you, particularly about the specific use of guiding catheters again.
One thing that I did not mention that in a real situation, I think just to go over the points that if we decide that we are going through the femoral route and there is tortuosity, the best way to avoid tortuosity is a long sheath, and then we know we have the short guide and use the soft tip guide like LIMA. So this is one case where you know that you are trying to engage with the LIMA, we are unable to engage because of the tortuosity, have very low threshold to change to left radial in LIMA intervention. And in cases where you know that many times the LIMA could have origin that is, what we say, even the origin could be difficult to engage with either a no torque or a LIMA guide. You can just leave the guide at the ostium and try to wire with the fielder or your workhorse wire, and once you wire, you're somewhere in the mid portion like I showed you, you can take a balloon support. In very tortuous cases, what we have done that you have one wire, and you decided you need a second wire because now your devices are not going down, that you can use your guide liner. So guide liner you can bring all the way to almost up to the mid portion of the LIMA, but you have to be very careful. It will be damped, and you have to be like I showed you, have your marks ready so you exactly know where the lesion is. Once you're able to wire, you cannot give a lot of dye to see how the vessel has behaved after you're done the PTCA. You can give very little dye and then you'll be able to place the stent, but the intervention has to be done very fast, because if you leave the guide liner in for a longer time, could lead to thrombosis. But like we showed here, I think in most often even these tortuosities are there, just go with your regular workhorse wire and a balloon support. You will be able to do it just with the balloon PTCA and a stent. And in cases where we know devices, especially even the second generation device stents are unable to go, you can do a good PTCA and come out, as long as you know, despite dissection, that you have a good flow in the distal vessels.
Anu, I'd like to emphasize again the other teaching point to keep it very atraumatic, and how you were able to straighten out the U-shaped curve. Don't advance the wire and cause further trauma, and the use of balloon, I think, was done very deftly. Samin, your symposium is around the corner. Everything coming okay with that?
Everybody in the view. Hello. Yeah. Yes, of course, we are getting preparation, and emphasis will be the same on the day one of the complex coronary with the bifurcation and the calcific lesions with the LV support. And secondly, on the day two of the structural heart disease, we try to do at least 3 to 4 tower cases in a various kind of scenario, and how they become user friendly and easy without any swan, without maybe a line, but with a transthoracic echo, conscious sedation, so that becoming patient could be discharged in the 24 to 48 hours. So that will be the goal, try to take things to the next level.
Excellent. Anu, you'll introduce us with the team around you?
Yeah, our team is, we have 2 fellows, Rahul, who is actually visiting from, he's come here from England, and we have Surbhi Madhwal. They are almost finishing their training, and both of them have their jobs set to go back. One is going back to, and Surbhi will be staying around here.
All right.
Samin and Anu, thank you.
Of course, we don't forget Vicky and Pablo.
Yes, yes, they always play a wonderful role.
Yeah, and we actually had a very nice demonstration for 2 days in ACC. Saturday was we had a 90 minute the live relay, and that day those cases will be put onto our CCC live webcast. One was the complex balloon valvuloplasty followed by orbital atherectomy of the left main LED and DES, and the second case was impella assisted left main intervention with the rotablation and put a bare metal stent because patient has a lot of bleeding disorder. Then second day we made an endovascular case in preparation for PCI because patient has a lot of PVD and had a CTO recanalization of the mid LED, and did a tremendous, fantastic job. And more importantly, which really took a lot of positive the comments, was the very tortuous shepherd crook right coronary, where use of guide liner was done to deliver the stent distally in a very atraumatic way in a very complex tortuous right coronary. Both will be available in our CCC webcast soon.
I also learned it was unusual that you were at ACC and Anu was doing the case here.
Yeah, the second day, yes, we did it. So first day I did, flew back, and I was on the panel next day while George and Anu did the cases here.
Fantastic. That concludes our session for today. Please join us next time, which is May the 20th, and thank you for joining us.